session in clinical pharmacology, and we continue our series about gastrointestinal pharmacology. We already addressed the peptic ulcer disease in the previous lecture and recorded already on the YouTube. And the next session for us will be nausea and vomiting. I tried to figure out another name for nausea and vomiting in other language. As you can see here, we have 10 languages for the nausea and vomiting in several languages. So for Spanish, French, German, Italian, Portuguese, and so on. So as a definition for nausea and vomiting, or we have another name for vomiting called emesis. So vomiting or emesis caused by the reflex due to the stimulation of vomiting center in the medulla. So we have the vomiting center in the medulla, but we have several factors will affect this vomiting center in the medulla. In this slide here, you can see we have possible causes for nausea and vomiting. This one maybe we can put it in our differential diagnosis. When you have patients suffer from nausea and vomiting, start thinking about this possible factors or possible causes for the nausea and vomiting. The first, for example, the first cause could be adverse effect from medication, could be opioid, morphine, and so on. So we have list of medication may cause nausea and vomiting. Second, we have systemic disorders. We have some disease, systemic disease may cause vomiting. So we have a question mark there. So when you have patients from nausea and vomiting, we have the list. The third one, pregnancy, the most important cause of nausea and vomiting, especially during the first trimester of pregnancy. Next, we have vestibular dysfunction. This is related to the inner ear. When you have this disturbances in the stabilities and related to the cerebellum, and we have the image or picture later on to explain or clarify the situation. Infections in general may cause nausea and vomiting. If you have hepatic disease, hepatic disorder, the most important factors here on the list: radiation therapy or chemotherapy. When the patient suffers from cancer and this patient will undergo to the chemotherapy treatment, the most important side effect from chemotherapy is nausea and vomiting. And one of the other factors, for example, from this list here, we have gastrointestinal obstruction, dysmotility, infections. So when you start to speak about obstruction, think about a tumor, for example. We have some maybe mass or like any foreign bodies lead to the obstruct the lumen of the GI system and lead the obstruction, especially talking about the upper part of the gastrointestinal system. Okay, this is I believe that this is an important section in nausea and vomiting. If we understand this diagram here, it will be easy for us to remember how to approach patients suffer from nausea and vomiting. We have all these points should be taken in consideration. So first of all, we need me and you together to look on the vomiting center. So we have the vomiting center here in the medulla. And then we have some stimulant coming from the higher center from the brain, could be from the cortex of the brain, could be from hypothalamus, thalamus, and could be from the meninges. This may be higher central nervous system send stimulant or impulses to the vomiting center. This is number one. So we have the vomiting center there. Then we move to the inner ear and vestibular system there. So if you have any disturbances in the inner ear, this will stimulate the cerebrum, and the cerebrum will stimulate the vomiting center. So we can see now we have the process. Inner ear stimulate the cerebrum will send impulse to the vomiting center and cause vomiting. What else do you have? GI system, stomach, and the upper gastrointestinal system. If we have any infections, if you have any, for example, tumor or any mass maybe obstruct the GI system, this will stimulate the vomiting center. What else? We have another important center called CTZ. CTZ stands for chemoreceptor trigger zone. Chemoreceptor trigger zone, and you can see here the GIT, gastrointestinal system. If this system stimulated, this will lead to stimulate two systems. Number one, vomiting center directly. Number two will stimulate the chemoreceptor trigger zone. So we have two pathways to induce vomiting and nausea according to the GI disorder, gastrointestinal disorder. Okay. Moving to what else we have. So if the patient undergo chemotherapy, it may cause nausea and vomiting. If the patient maybe undergoes radio irradiation, the patient suffer from infection due to the bacterial infection or viruses infection may cause the nausea and vomiting. But you can see here this medication here, chemotherapy, radiation, bacteria affect the GI system. So stimulate GI system. When the GI system is stimulated, this will lead to stimulate the medulla, vomiting center, and CTZ. Moving to the drugs, we have so many drugs engaged in inducing nausea and vomiting. As you can see, the drugs work on two possible mechanisms. Number one, for example, opioid, cytotoxic drugs, digoxin, L-dopa, apomorphine, cholinergic drugs. This medication works on two mechanisms. Number one, by stimulate or irritate the GI system, gastrointestinal system. Number two, will stimulate the chemoreceptor trigger zone. So now we have another group of medication we talk about. So we almost cover the most popular causes of vomiting. Could be ear, number one. Could be drugs, number two. Could be, for example, other cases here, number three. Could be direct stimulation to the GI system, number four. Could be something related to the higher center, for example, number five, such as smell, pain. Okay, here we have sometimes we have smell, we have pain, or like fear. All these may stimulate the central nervous system and cause vomiting. So we've done roughly with the causes, but here we try to apply our medication. We need to know what type of component, what type of targets do you have in the central nervous system. Okay, I will clean all these scratch on the board here. I will clean it. Then we move to our target. So our target will be the receptor in this image or this nice picture. Okay, our target will be the receptor. So in the vomiting center, if you look on the vomiting center, they said we have receptor there. What type of receptor do you have in the vomiting center? Okay, this is the list of receptor, vomiting center receptor. We have muscarinic receptor, M1 receptor. M stands for muscarinic. We have histaminic receptor, H1 receptor. Then we have D stand for dopamine receptor. But remember, we have D2 receptor here. So D2 receptor, dopamine receptor 2 in the vomiting center. Then we have serotonin receptor. What type? 5-hydroxytryptamine 3 receptor. Then they said we have opioid receptor in the vomiting center called mu and delta. So another, maybe you can see the opioid here. Okay. Then we have neurokinin receptor and CB1 cannabinoids receptor. So all these receptors, you can see we have 7 types of receptors involved in the pathophysiology of nausea and vomiting. Okay, this is talking about the vomiting center, what type of receptor. Okay, moving to the CTZ, which means is chemoreceptor triggered zone, and the CTZ, you can see this one here is on the blood-brain barrier. So it's like a barrier between the central nervous system and the peripheral nervous system. So, or the peripheral system in general. So the barrier here, kind of barrier between the two main organs, central nervous system and peripheral system. Okay, the question now, what type of receptor do you have in the CTZ? You can see here we have muscarinic receptor M1, we have dopamine receptor D2, we have serotonin receptor T3, then we have cannabinoid receptor CB1. So all these receptor will be our target. So if I ask you what type of receptor do you have in the vestibular system or in the inner ear, So what type of receptor do you have in the ears? They said we have two main receptors there. We have H1 receptor stand for histamine. We have M1 receptor stand for muscarinic receptor. So please remember, when the patient suffer from motion sickness due to the vestibular system disorders, remember we have two receptors there, H1 receptor, M1 receptor. That give us warranty to use medication to block this receptor. So when you have the patient suffer from motion sickness, okay, this is a drug of choice to block H1 receptor or block M2 receptor or both of them together. I hope this give you like simple explanation about our target. The last one here is very important for us in the GI system. What type of receptor do you have in the GI system? They said we have 5-HT3. Here we are talking about nausea and vomiting, but we have several receptor in the GI system. In the GI system we have epinephrine. In the GI system we have norepinephrine. In the GI system we have substance B. In the GI system we have so many receptors there, but it's not our topics. So here we try to focus on which receptor involved on nausea and vomiting. They found it's like 5-hydroxytryptamine 3 or serotonin receptor type 3. Okay, so now we cover almost the most related receptor. In the vomiting center, we have several type of receptor in the CTZ, vomiting center, and the CTZ in the inner ear, and in the GI system. So you can see the interconnected between all these organs. And the last one here, we discussed the higher center, the cortex. Fear, smell, pain may cause or induce vomiting. Okay, now we start with speaking about the medication, anti-vomiting or antiemetic drugs. You can see here they said chemotherapy, cancer chemotherapy maybe cause 70 to 80% of patients suffer from nausea and vomiting. So during the treatment, before, or after, the patient, 70 to 80% of patients experience nausea and vomiting. When you say during, before, or after, because we have some case called anticipatory nausea and vomiting. When the patient think about the chemotherapy, they start suffer from nausea and vomiting. So this one like before chemotherapy. So we have a abbreviation here, CINV. CINV stand for chemotherapy-induced nausea and vomiting. CINV. So for example here, when the patients suffer from nausea and vomiting due to the chemotherapy, okay, nausea and vomiting, they said this maybe symptoms may affect the quality of life. That's correct. These symptoms may lead to the patient to reject the treatment. They said, I'm not going to take this medication because this medication caused me a lot of disturbance, a lot of nausea and vomiting. I don't like it. So the patient will reject this treatment. Okay, this is number two. This is number one, quality of life. Number two, rejection. Number three, so what happened here? If we left the patient without treatment, vomiting and nausea will lead to the dehydration and metabolic imbalances and nutrient depletion. So all these may be required or demand treatment for the nausea and vomiting in patients suffer from due to the chemotherapy or like chemotherapy-induced nausea and vomiting. Okay, list of medication here, like summary. It's not include everything because we are going to cover it in the next slide. Anti-emitting agents, we have anticholinergic such as cobalamin, atropine. We have anticholinergic or antimuscarinic. Then we have serotonin receptor antagonist. You can see most of the medication considered antagonist. The only one agonist, cannabinoids. And we have cortisone is not belong. So two things not belong to the but the other will be antagonist. So you can see here we have cholinergic antagonist, muscarinic antagonist, serotonin antagonist, dopamine antagonist, antihistamine, neurokinin antagonist or blocker. So what we have here, most of the list antagonist. We have only two exceptions, cannabinoid agonist, and we have glucocorticoids. Okay, we need you to be familiar with this medication. The most popular medication here, you can see here antihistamine. We have diphenhydramine, dimenhydrinate, diphenhydramine, hydroxyzine, and meclizine, for example. For dopamine antagonists, we have metoclopramide, prochlorperazine, droperidol. Uh, Most important effective medication, serotonin antagonist. Ondansetron, granisetron, bolansetron, dolanesetron, all these suffix with a citron. So the citron stands for serotonin, citron, serotonin, ondansetron, a granisetron, okay? Benzodiazepine, sometimes we use benzodiazepine, lorazepam, and diazepam. We are going to discuss it with you. Okay. Okay, start with the first group of medication. Okay, start with the first group of medication. You can see the list here. What we have here on the list, we have antihistamine and anticholinergic drugs. Antihistamine, you can see the list here, diphenhydramine, the brand name Benadryl. Then we have dimenhydrinate, Dramamine, the brand name, and meclizine. Moving to the last one on the list here, hyoscine or scopolamine. So this medication considered like carry both of this effect like antihistamine and anticholinergic drugs. So try to in this slide try to tell us that this medication considered like weak and antiemetic medications. So this medication considered like weak antiemetic medications. We don't use it for patients suffer from CINV, chemoreceptor induced. We don't use it because it's considered like weak. We look for something like strong vomiting treatments, such as when you have here we recommend to use something like ondansetron or like metoclopramide, and other maybe medication belong to the dopamine antagonist. So for the chemotherapy, we prefer to go with something strong. Speaking about the antihistamine and anticholinergic, they said this group of medication is like useful in treatment and prevention of motion sickness. So if the patients are from motion sickness due to the riding plane or for example, going with the trip on the sea, so we prefer to use this medication before or during suffer from the treatment. So this group of medication used for prevention and treatment of motion sickness. Patient here may suffer from some side effect due to the anticholinergic dizziness, sedation, confusion, dry mouth, cycloplegia, urinary retention. So all these may be covered under the effect. If you remember, for example, the effect of atropine. When you remember atropine here, it's like atropine effect. When you talk about blurred vision, cycloplegia, urinary retention, this one belongs to the atropine. So I will ask the question here, why anticholinergic medication cause urinary retention? So why anticholinergic drugs such as atropine cause urinary retention? I will leave it for you, and then we go back again to answer this question. Okay. Okay, as you can see in this slide here, we are talking about the medication now. We have four medication belong to the antihistamine, anticholinergic. The first group of medication, we have diphenhydramine and dimenhydrinate. We have Benadryl as the brand name, and then we have Dramamine as the diphenhydramine, Dramamine as a brand name. So you can see here the diphenhydramine is like antihistamine. This is antihistamine medication. Antihistamine medication used for symptom of allergy, high fever, and common cold. This is antihistamine. It's more popular for that. Diphenhydramine is like first generation antihistamine, but at the same time have significant anticholinergic and sedation effect. So speaking about diphenhydramine, we have three main effects. Number one, H1 blocker, H1 receptor blocker. Number two, okay, this medication considered like muscarinic receptor blocker. And number three, this medication considered maybe having some sedative effect. So the dimenhydrinate, Dramamine, cause all these side effects or carry the properties of the H1 blocker, muscarinic blocker, and sedative effect. So this medication considered like non-selective may cause side effect, and we discussed the side effect in the previous slide. Diphenhydramine, Benadryl, here you can see it. We use it for patients from allergy, high fever, or common cold. Okay, we still in the same topic, antihistamine, anticholinergic. We have meclizine. Okay, I will go back. We have meclizine, and then we have scopolamine or hyoscine. Meclizine is H1 receptor antagonist, antihistamine antagonist. Okay, the advantage of meclizine has minimum anticholinergic effect, minimum sedation. That's we prefer to use this medication. For example, if you compare it with the previous medication, because the previous medication, diphenhydrinate, maybe it's non-selective, black H1, black muscarinic sedative effect. Okay, moving to the meclizine less less effect on the cholinergic and less sedative effect, and we prefer this medication meclizine for prevention of motion sickness, and we prescribe to the patients from vertigo due to the liberinous dysfunction. So we have two cases we can prescribe meclizine for the situation here. So we have the meclizine here, and you can see we have the plane, we have the car, and then we have the ship here. So all these could be used for and we have like antiemetic medication here. Okay, moving to the last medication in this group, antihistamine, anticholinergic, we have scopolamine. They said scopolamine, muscarinic receptor antagonist. So which of these medication muscarinic receptor antagonists? Scopolamine. Okay, scopolamine, one of the best agent to prevent motion sickness, and available orally or parenterally or transdermal patch. So we have list of medication now. I will go back again. We have diphenhydramine, we have dimenhydrinate, then we have meclizine, and we have hyoscine. Here we have some medications on the list here. You can see here we have meclizine, for example, metoclopramide, then we have scopolamine, and we have other medication, prochlorperazine, and we have droperidol. We have other group of medication in the list. Okay, so we're done with the first group of medication. We discussed the antihistamine, anticholinergic, and this group of medications, antihistamine, anticholinergic, mainly used for patients suffer from motion sickness. So please remember this group of medication, if you use it for patients suffer from motion sickness mainly. Okay, moving to the second group of medication now, we have dopamine antagonist. For dopamine antagonist, we have three main groups. We have antipsychotic, phenothiazine, then we have antipsychotic, butorphanol, then we have antipsychotic derived from benzamides. Okay, start with the first group derived from phenothiazine medication. We have chlorperazine, promethazine, and we have olanzapine. So this is a group of medication carry the properties of antiemetic drugs. Okay, regarding the antipsychotic phenothiazine, we have chlorperazine, promethazine, olanzapine. This medication carry the effect of antiemetics mediated through the inhibition of dopamine, number one, and also inhibit muscarinic receptor, but the main effects considered like blocking the dopamine receptor. This medication also blocks the muscarinic receptor. Okay, this medication carries the effect of sedative effect. So we have properties here. Dopamine receptor will be affected with the antagonist on this group. Dopamine receptor, histamine receptor, then we have sedative effect for this group of medication. Okay, this medication maybe has efficacy or effective against low to moderate drugs caused by chemotherapy. Okay, so effective against low to or moderately metogenic chemotherapy agents. So chemotherapeutic agents, CINV. If you have it like moderate to low to moderate effect, we can start using this chlorperazine or olanzapine. Antipsychotic butorphanol. Antipsychotic butorphanol, we have one medication here, droperidol. This medication prescribed intramuscular or intravenous. This medication extremely inducing sedation, so may cause hypnosis, induce sleeping there. Uh, we normally use it during the to induce sedation during the endoscopy or surgery. Sometimes we combine this medication with the opioid and benzodiazepine. But the drawback from this medication for the droperidol belong to the butorphanol. This medication may cause prolonged of QT interval. Droperidol, prolonged QT interval, and should be reserved for patient who maybe for patient with inadequate response for other agent, for example. So for this reason, we don't prefer to use this medication as first step or first option or first choice. So droperidol is not for, but we use it for to benefit from the sedative effect of this medication. Moving to the another medication belong to the dopamine antagonist. We have metoclopramide. They said metoclopramide with the high doses is considered like very effective against the hematogenic medication or drugs such as cisplatin. Cisplatin considered like anti-cancer medication and prevent emesis by 30 to 40% of patients. So this is very good medication, very effective medication in preventing nausea and vomiting due to the chemotherapy by 30 to 40%. Metoclopramide may cause extrapyramidal symptoms with this will limit use for long time treatment or with the high doses. So long treatment or high doses may cause extrapyramidal effect with the metoclopramide. Okay, the question from this slide here, maybe we can create this question by asking about which of these medication belong to the dopamine antagonist and used to treat patient undergo the endoscopy or surgery to provide sedation, but this medication may cause a QT interval. So if you answered droperidol, you are correct. Okay. Which of these medications on the list may cause extrapyramidal symptoms? Metoclopramide. Okay. Which of these medication may cause dopamine receptor antagonist, H2 blocker, and sedative effect? Okay. We have prochlorperazine, promethazine, and olanzapine. Okay. So we're done with the dopamine antagonist. We have several questions from this slide here. We already addressed the question with you. Then we move to the benzodiazepine. The benzodiazepine alone is not considered, are not. So benzodiazepine are not anti-vomiting medication alone. So we don't use it. When the patient suffers from vomiting, we don't use, for example, benzodiazepine as anti-vomiting. But what happened there? We have lorazepam and diazepam, two medications, lorazepam and diazepam. These medications reduce anxiety and stress. And you remember that from the beginning, we have the chart. We said fears, pain, smell may induce higher center in the brain, and this higher center will stimulate the cortex. So when you have fear or anxiety, so we can use benzodiazepine to relieve anxiety, and then this will reduce risk of vomiting and nausea. So this maybe explain the mechanism why diazepam could be used. They said diazepam reduce the anticipatory vomiting and nausea due to the anxiety. So when the patient only think about the chemotherapy, they start suffer from vomiting without treatment. Again, the same situation apply here for corticosteroid. We have dexamethasone, methylprednisolone. This group of medication, we don't use it alone. Normally, we use it in combination treatment. So it's not alone. This alone is not. We don't use cortisone only as by itself, cortisone or dexamethasone only as anti-vomiting medication or anti-emetic, but we use it in combination with the serotonin antagonist, 5-HT3 antagonist. And they said this combination treatment here maybe enhance the effect of the receptor. So the cortisone, they found cortisone enhanced the efficacy of the serotonin receptor antagonist. Moving to the next group of medication could be used to relieve nausea and vomiting. We have cannabinoids. Cannabinoids, we have droperidol, we have nabilon. Droperidol derived from marijuana plants, and droperidol stimulates CB1 receptor on the brain. If you remember, CB1 receptor available in two places, available in vomiting center and available in CTZ, common receptor trigger zone. Okay, so what we have it here on the emitting center trigger zones, and this medication used as medically for as an appetite, increase appetite. This medication also has the effect of antiemetic effect, uncommonly used in the practice. If the patient take chemotherapy, we don't use cannabinoids. It's not like a drug of choice. Nabilon, closely related to the marijuana, and approved by the USA now for the treatment, nabilon. So you can see the medication name here, dronabinol, derived from marijuana. We have nabilon capsule, and we have it in both capsule pharmaceutical form, and this we use for the by affecting the CB1. So the question now for us, is this agonist or antagonist? This medication, dronabinol and nabilon, considered agonist. What that mean? This medication stimulate CB1 receptor. So this medication stimulates CB1 receptor. Okay, the most of the medication we already discussed or are going to we are currently discussing is like blocking the receptor. For example, H1 blocker. We have muscarinic blocker. Then we have 5-HT3 blocker. So most of these medications considered like a blocker. Neurokinin 1 blocker. So you can see here most of the medication blocker. The only exception here, please remember, CB1. CB1 stands for cannabinoids receptor 1, and our medication dronabinol or nabilon considered like agonist, mean able to stimulate this receptor. Okay, moving to the next group of medication, we have three drugs in this group. We have neurokinin receptor antagonist. So we have neurokinin receptor antagonists here. Neurokinin receptor antagonist, abribitant, and nutibitant and rolabitant. This is available oral. So abribitant, nutibitant, rolabitant, oral formulation. We have one medication available from this list, like fosfabribitant. Fosfabribitant, this is available IV infusion. Okay, and when we prescribe this one and enter the human bodies, when this one enter the body, this will convert to the abribitant. Okay, so when in the human body will be, when we prescribe it infusion, this will be metabolized to the abribitant. What we have here, we have combination treatment for the like strong vomiting and nausea. We suggest using some combination treatment. For example, neurokinin receptor, serotonin receptor, and cortisone. So when you use this combination treatment, neurokinin receptor, abribitant, serotonin receptor antagonist, and dexamethasone, so neurokinin 1 antagonist plus 5-HT3 antagonist plus dexamethasone. Okay, they found this one control 80 to 90% of vomiting. This is great. This give us maybe warranty to use this combination treatment between anti-emitting or anti-vomiting medication to control nausea and vomiting. Okay, then we have another medication recently approved by the 2016. It's not recently now. We can remove this one because like around Nutubitant and bolancentrone combination. So two medication in one tablet, nutubitant and bolancentrone. Okay, so you can see the combination work between nutubitant and bolancentrone as a capsule here for the vomiting, nausea, abribitant capsules. Then we have rolabitant tablets, and the last one here on the list, you can see the fosagribitant available like injection for IV infusion. Okay, regarding antiemetic drugs, the another group here, I believe this is the last group for the antiemetic or anti-vomiting medication. We are speaking about the 5-HT3 antagonist. 5-HT3 antagonist. HT stands for 5-hydroxytryptamine 3. So 5-hydroxytryptamine, and this one belongs to the serotonin receptor antagonist. But we are talking about serotonin receptor 3 here, because we have serotonin receptor 2, serotonin receptor 1, 4, 5. So we have several types of serotonin receptor. So we three or four group of medication available in the practice. We have ondansetron, we have dolasetron, granisetron, bolasetron, and the suffix there, citron, serotonin citron, ondansetron, zofran, enzymant, dolasetron, granisetron, bolasetron. Okay, the medication, you can see the ondansetron available tablet, ondansetron available like in injection. We have here dolasetron, and then we have bolasetron. So we have all these medication available in the clinical practice, and considered very important medication for chemotherapy-induced nausea and vomiting. Very important group of medication for this case here. Okay. Speaking about in more details about this medication. Okay, so we have now we start talking about some details about the serotonin receptor antagonist, serotonin receptor 3 antagonist. Here they said ondansetron, granisetron, dolasetron, 3 medication. Please remember this 3 medication: ondansetron, granisetron, and dolasetron, 3 medication, have short half-life. Serum half-life is short, 4 to 9 hours. Okay, could be moderate, but we consider like 4 to 9 hours. This medication prescribed once daily, oral or IV. You can see we have some injectable form. This medication in general, all the serotonin receptor antagonists, very effective against the high hematogenic activity, such as cancer, chemotherapy, or radiotherapy. The bolanocitron, the advantage of bolanocitron, has greater affinity to the serotonin receptor. And what else? The longer half-life, 40 hours. So bolanocitron, longer half-life. If you look on the rest, what we have, 4 to 9 hours. So which of the following serotonin receptor antagonist has longer half-time? Serum half-life, longer serum half-life. Which of these serotonin receptor has longer half-life? So we have bolanocitron. Okay, how this medication work? As you can see here, if you remember, if you go back to the image in the beginning, we have 5-HT3 receptor, and this receptor available in the vomiting center. This receptor available in the CTZ, chemoreceptor triggered zone, and this receptor available in the this receptor available in the vomiting center and the chemoreceptor trigger zone. What else? What is the number 3 here? Can we speak about the GI system? Gastrointestinal tract. So we have the 5-HT3 receptor. So this medication, this group of medication, affect two main places: central effect, vomiting center in the medulla, and the CTZ in the blood-brain barrier. and peripheral effect on the GI system. Okay, 5-HT serotonin receptor antagonist 3 effective in the prevention and treatment of nausea and vomiting in the following cases: if the patient suffers from chemotherapy-induced nausea and vomiting, radiation therapy, post-operative therapy. So 3 cases is considered like most effective medication. We have prevention and the treatment, chemotherapy, radiation therapy, and post-operative procedure. This medication speak about adverse effect, unwanted effect. This medication normally well tolerated. Common side effect: this medication may cause headache, nausea, constipation. They said this medication in general may cause QT interval, but the most important one by inducing QT interval will be dolacetrone. So dolacetrone may be considered like offensive factors by inducing QT interval. So if the patient suffers from any heart abnormalities, we don't recommend to use dolacetrone in this patient. The dolacetrone should not be administered to the patient suffering from QT interval, prolonged QT interval. This is contraindicated. So the question now, we have a medication, dolacetrone, considered like contraindication, CI, in patient with prolonged QT interval. Okay, give me another medication belong to the antiemetic medication may cause prolonged QT interval. Okay, so regarding the prolonged QT interval, if you answer this question, what we have here, droperidol. Droperidol may cause prolonged QT interval. Dolacetrone cause prolonged QT interval. What is droperidol? Belong to which medication? Dopamine, D2 dopamine receptor antagonist. Okay, so now we have 2 medication may prolong QT interval. Dolacetrone belong to the serotonin antagonist, prolong QT. Droperidol belong to the dopamine D3, D2 receptor antagonist also. Okay, okay. Let me try to work with you and answer the question about the. If you remember, we asked the question about atropine. Then we have, for example, scopolamine. And what else? We have another medication, and they said this medication is considered like anticholinergic drugs. And my question was, if you remember, why this medication cause urinary retention? Question mark. So we gave you this question, and now we try to answer this question with you together. Before we look on the question, the answer for this question could be start with ask ourselves what is atropine or scopolamine. So as you can see, atropine, scopolamine, anticholinergic medication. Before we move to the explanation what happened there, we have to look. Okay, we need to be familiar with the acetylcholine effects on the urinary effect on the genitourinary system or the genitourinary tract. So what happened here if you speak about the bladder? Okay, talking about the bladder here. Okay, so here the bladder. Okay, so if you talk about male, for example, we have the prostate here. Okay, so what they said there in the bladder we have muscarinic receptor. So in the bladder we have muscarinic receptor. In the bladder we have beta 3 adrenergic receptor. Okay, in the bladder what we have else? We have alpha 1A receptor, alpha adrenergic receptor, and on the bladder neck. So all these receptors available in the bladder. We have muscarinic receptor, beta 3 receptor, alpha antagonist. Our topic, our questions focusing on the muscarinic receptor. Muscarinic receptor. What is the effect on the muscarinic receptor on the bladder? Now, if you prescribe acetylcholine, acetylcholine will stimulate muscarinic receptor, and that means this will be stimulated. And at the same time, they found we have sphincter, two sphincter, inner and external sphincter, and we have muscarinic receptor here in the bladder. So the muscarinic receptor available in the two type of is available on longitudinal muscles and available in circular muscle. So the acetylcholine stimulate muscarinic receptor in both. So when you stimulate muscarinic and the longitudinal muscle, this is a longitudinal muscle. So the result will be contraction. Okay, the result will be contraction. What happened to the circular muscle? Sphincter here. We talk about sphincter. The result will be relaxation. Okay, now we understand the effect of acetylcholine on the bladder. Okay, shall we move to the what happened if you apply anticholinergic? We oppose the action. We are going to oppose this action there. So when you have atropine or scopolamine, we try to oppose the action of acetylcholine. So for example, when you prescribe atropine block muscarinic receptor. So what we have here is longitudinal muscles, and we have circular muscle. So with the longitudinal muscle, we are going to have opposite effect. We have relaxation of longitudinal muscle, relaxation of longitudinal muscle. What happened to the circular muscle, sphincter? We have contraction. Okay, what is the result here? When you have circular muscle contracted, the result will be urinary retention. Okay, this gives us maybe important concept to be very careful when you prescribe this medication to the patients suffer from benign prostatic hypertrophy, because this patient already suffer from subtype of urinary retention, and if you prescribe this medication to the patient, you aggravate the symptoms. Therefore, we don't recommend to use this medication in patients suffer from benign prostatic hypertrophy. Okay, so we answered the question for that. Okay, so this table summarizes the information for antiemetic drugs. We discussed scopolamine with you. Scopolamine considered like a muscarinic antagonist. We have dimenhydrinate, diphenhydramine. We have considered like H1 receptor blockers. We have serotonin receptor antagonist. We discussed all these information. We addressed the QT interval with you. Metoclopramide affect the dopamine receptor, for example, in two places. It's very effective in the chemoreceptor diabetic gastroparesis. GERD was already covered in the other maybe topics. Metoclopramide carry the risk of extrapyramidal effect, tardive dyskinesia, dystonia, diarrhea. Then we have cortisone, we have abribitant. All these information covered, and this table summarizes the information. The question now from this table, we can create several questions. Which of these medication used for motion sickness? Okay, which of these medication used for chemotherapy-induced nausea and vomiting by blocking serotonin receptor? Which of these medication block dopamine receptor and used for the gastroparesis? Okay, we can create several questions from this slide here. Okay, now we have a case study. A 68-year-old individual suffer from heart failure, and this patient is diagnosed with ovarian cancer, and she's on the cisplatin and starts suffering from severe vomiting as a side effect. Which of the following medication may offer the most effective and relief emesis in this patient without worsening the cardiac condition? So we have case now. We have patient with heart failure, patient suffer from cancer and treated with cisplatin, and now suffer from severe vomiting. Okay, so we try to treat the vomiting without worsening the heart condition. So we have droperidol, dolasetron. Which of the following medication would offer the most effective to relieve symptoms? So I will start with the first one, droperidol. Yes or no? This medication, we don't use it because this prolonged QT interval. Dolasetron, no, prolonged QT interval. Prochlorperazine. Okay, so what do you think? What do you think about prochlorperazine? Okay, moving to choice number D, or letter D, with the bolasetron. Bolasetron, that maybe that will be the correct answer for this case. Why we don't use prochlorperazine in this patient? Okay, let me share the screen with you for this one here. So you can see what we have here. They said prochlorperazine may increase the risk of QT interval prolongation. Best to avoid the use with a potential QT prolonging medication. So we don't recommend to use it. For this reason, the correct one will be bolasetron. Okay, moving to the nausea and vomiting during pregnancy. What type of medication we are going to use? I prefer to review this article with you together. This article published in the American Family Medicine, an American family physician. Okay, so what we have here, we have the article here published, nausea and vomiting of pregnancies. I will scroll down to the medication available for this case. Treatment. Okay, we have some ginger, for example. They start talking about ginger as a possible remedy for vomiting and nausea. Pharmacological treatment here. Pharmacological treatment, I will try to make it bigger a little bit. Okay, good. Another, okay, that's great. So you can see here from the graph, even if the graph is small, I'm not sure if I'm able to maximize. Okay, so what we have here, we can see number one, vitamin B6, pyridoxine, doxylamine. Doxylamine belongs to the muscarinic antagonist. Then we have, this is the primary, B6, doxylamine, the most important medication popular in clinical use for nausea and vomiting of pregnancy, vitamin B6, doxylamine. Okay, then when we have secondary therapies there. Start talking about dimenhydrinate, diphenhydramine. Then we have hydroxyzine, meclizine, metoclopramide, ondansetron, promethazine. So we have list of medication. And then we have side effect here. So the most popular one, please remember, B6, vitamin B6, doxylamine. Can we use other group? Yes. Okay. So if you look on droperidol prolonged QT interval and may cause torsade de Bond and prolonged QT interval. We don't recommend to use it. Okay, so we cover here we try to remind you, we have vitamin B6, and what else we have? Doxylamine. And doxylamine belongs to the muscarinic receptor antagonist. At the end of this lecture, I would like to thank everyone for your time and listening to this record. I hope you get the maximum benefit from this topics covering the nausea and vomiting, anti-emetic, anti-vomiting medications, talk about mechanism of actions. We spoke about the clinical use and adverse drug reaction, contraindication, nausea and vomiting during pregnancy, chemotherapy, radiation therapy. We cover motion sickness. We speak about QT interval. So many things covered in this lecture. I hope you get the maximum benefit from this lecture. Thank you so much and have a great day.